Hello, welcome to this video. My name is Hannah. I'm a UK registered nurse, university lecturer, and I've been an NMC OSCE programme lead. And if you're new to this channel, I share advice and teaching and short tutoring videos to help you prepare and self-study and pass your NMC OSCE exam. In this video, I'm going to finish off my APIE tutorial series and go through the fall and fracture APIE scenario. So we're going to look at what a fall and fracture is, the main assessment priorities, possible care plans, potential medications and implementation, and some key recommendations for the evaluation station. Okay, so fall and fracture is one of the 10 APIE conditions that you can get in the adult NMC OSCE exam. I've got tutorial videos on all of them, so please head over to my APIE playlist and have a look at the rest of those as well. So normally in this scenario, the fracture is a fractured neck of femur. The patient has had a fall, maybe at home or outside the home, and they have broken their hip. You could potentially have other type of fractures, but this is common and the most common one that we see. And this, what happens is there is a fracture basically from the femoral head to the femoral shaft occurring within the joint capsule. And there's the risk here really of disrupting the blood supply to the femoral head and getting avascular necrosis there. So that's kind of one of the risks with it. You can go to the NICE guidance, CG124, and look at the NICE guidance and recommendations for the treatment of fall and fracture. That will take you through things such as diagnosis, management, what type of theatre options as well. I'm going to talk about a couple of those with this. So you can grade fractures. So depending on the severity, you might see what we call the garden grading. So a type 1 is an incomplete fracture, type 2 is a complete fracture but without any displacement, type 3 is a complete fracture with some partial displacement and fracture fragments, and a type 5 is a total complete fracture with total displacement. And so depending on the type of grade depends on the surgical procedure which is carried out. So causing the risk factors, so this most commonly is caused in falls by older individuals that already have weakened bones due to osteoporosis. In terms of our NMC exam, we should most probably be expecting our patient to fall into that category. So they might be older, they might have some history of osteoporosis as well, but you can get this in younger people as well, normally from high impact trauma, so things such as road traffic accidents, for example. So symptoms, so someone will present obviously with pain in the hip or the upper leg. There might be swelling and bruising around the hip and upper leg as well. They're not able to stand or put weight through that affected hip and leg, and they're obviously going to have difficulty moving that hip and leg as well. And you might see the affected leg might be at a different angle or is shorter than the unaffected leg, so that's quite a classic symptom. So treatment, so normally do need surgical treatment, and again, depending on the type of fracture, we can do things such as putting screws and plates in, or if it's one of like a grade 5 or 4, normally they need a total hip replacement. These patients are going to be on bed rest until theatre, so this is an important point to be aware of in terms of your NMC OSCE exam, and just thinking in that assessment station, particularly whether that patient is going to be on bed rest, which they should be. Pain management is very important. We need to ensure they have got good pain relief until waiting surgery, and then rehabilitation. So making sure that they get their physical therapy and on that first day post-op, patients can get up and start to mobilise, and we want to be doing that and getting them back into kind of mobilising and regaining strength as quickly as possible. So in terms of you in your A3 assessment and in terms of your assessment station, so same principles apply through all these APIEs. So you still need to do your complete A3 assessment, so all the requirements of that. We might be wanting to think about fluid balance as well. This patient might be nil by mouth waiting for theatre, so just thinking about fluid input and output, whether we need any supplemental IV fluids. Pain assessment and management is very important. Sometimes the patient hasn't got any pain in your assessment station. This throws nurses off because they've had some good pain relief maybe in the ambulance or prior to you arriving. So don't be thrown if there's no current pain, but the patient can be at risk of pain. In our holistic part of our assessment around physical, we definitely want to find out more about the fall history, so potential causes, mobility, are they using any aids, do we need to think about a physio referral, or are there any other physical causes of falls, so a history of low blood pressure, reduced heart rate, for example. We need to be aware of the risk of pressure damage. Like I said, these patients are going to be bed rest until 1 day after theatre, and they are going to be at risk of pressure damage. So again, if we've got time, giving some advice on kind of pressure damage prevention, and that's a good problem as well to do a care plan on. The rest of our holistic assessment, so just again thinking about that psychological support and reassurance for theatre. Sometimes I know patients might be quite scared of going to theatre, they might be scared of losing their independence and their mobility, so just kind of reassuring those things, and that patients will be able to have rehabilitation and support to get back up on their feet. We might be thinking about any home adaptations and occupational therapy referral. Again, just thinking if that person is has any dependents at home, is a carer, and whether we need to consider any support for that discharge period as well. And always good to check for any spiritual needs prior to people going to theatre as well. So planning, so there's lots of potential care plans you can do for this situation. Like I said, you could do pain, risk of post-operative pain, there's the risk of post-operative wound infection, risk of falls, obviously very relevant, potential risk of post-operative bleeding, and risk of pressure damage. And I think it's always really good to keep your care plan simple and specific. And I think for this scenario, risk of pressure damage is a really simple but important care plan that you could write for this patient. So our problem would be Reginald is at risk of pressure damage due to being on strict bed rest and reduced mobility due to fractured neck of femur. Obviously, our aim is going to be to prevent pressure damage and maintain normal skin integrity. And our re-evaluation timeframe is going to be today and then every 2 hours, because that's going to be how often we are moving that patient to assess and check for their pressure damage and skin integrity. Lots of interventions we can do for pressure damage. So again, thinking about those really specific ones related to management of skin integrity. So obviously we're going to have our point on gaining consent. We're going to do our news 2 observations as per policy. We need to risk assess Reginald for developing pressure damage using the Braden risk assessment tool. So we should be assessing Reginald's pressure areas with every position change, and we should be checking for signs of pressure damage, such as redness, blisters, discoloration. Think about all those things you would normally check in a patient's skin and put those in your care plan. We should also be repositioning Reginald every 2 to 3 hours to prevent pressure damage development, and we should be using correct manual handling equipments and techniques to prevent friction and shear skin injuries. Administering analgesics here is relevant to support pain-free moving and repositioning. We can also instruct Reginald to change position and relieve pressure on key body areas, so where they might be able to move a heel, elbows, back of head, so support that kind of independence with changing position where able. We can provide a pressure relieving mattress as well. And we can educate Reginald once he is eating post-surgery to maintain a well-balanced diet and good hydration, because we know that promotes good skin integrity. Reginald is going to need the cool bell. That's going to be quite important because the patient is going to be on bed rest, and we'd obviously document all care. So really good pressure relieving care plan there with lots of specific points around the management of skin integrity. And that's a care plan which you could maybe pour into lots of different scenarios across the APIE, because a lot of your patients are going to have potentially reduced mobility due to their condition and be at risk of pressure damage. So implementation, so obviously analgesics, we need to look out for analgesics for this patient, so simple things such as paracetamol. There may be some post-operative prophylactic antibiotics, so just be aware of those, and obviously look out for your allergies, your penicillin allergies, and your antibiotics with Silonin. There might be some post-operative anti-sickness, for example, so metoclopramide or cyclizine. And then obviously, depending on the patient's history and background, there may be some specific medications due to their past medical history. Occasionally, there's things like oxybutynin hydrochloride, which is for urinary frequency, antispasmodic to help reduce urinary frequency. They might be on things such as lansoprazole, maybe gastric protection, being nearby mouth, or potentially a history of reflux disease. They might also have, a history of antihypertensives or maybe diabetes as well. So just be aware of those common medications for common presenting conditions in the more older population. Evaluation, and again, it depends who you're handing over to, but you might be handing over to the next nurse on shift. Your patient's most probably now going to be post-op. You could be transferring them from theatre to the ward. or again, just to the next nurse on shift. So think about that kind of standard post-operative nursing care that needs to be carried on and continued for your patient in order to maintain safety. So we'd want to do post-operative news 2 monitoring as per the policy. We'd be monitoring for any post-operative complications such as infection, bleeding and thrombosis. We'd want that person to continue to assess pain and administer analgesics. Monitor fluid input and output is important. Maybe administration of antibiotics and medications as prescribed. We'd want them to review the wound when we're in the wound dressing in 24 hours. Maybe we need to hand over when sutures need to be removed. So if you've got that kind of information in your briefing, then make sure you use it. We can encourage mobilisation kind of 1 day post-op, and that's following the NICE guidelines, which I said at the beginning of this presentation. And if you have got any social care issues, you would want to get your person who you're handing over to follow those up. Again, chase any referrals such as physio, occupational therapy. So I hope that's helpful. They're quite popular, these APIE tutorials. It's really good to look at the APIE and the condition as a whole, think about what that condition is, how it's managed, what are those problems for the patient, what are those core medications that we might be expected to give, and therefore it takes away a lot of the unknown for the OSCE and hopefully a lot of the anxiety, but also deepens your knowledge for when you go into UK nursing practice. Please like, share and subscribe my channel. It is slowly growing and I'm really pleased with that. Thank you for everyone who puts their comments. I try and answer those, as I'm able to within the time that I'm allowed. And well done to everyone that is passing using my channel. It's really great to see your feedback and see your success. I am available for tutoring, so one-to-one tutoring, or I have a small monthly online group as well. Really small, maximum of 8 nurses, direct teaching plus access to my digital learning platform. I've also got just my learning platform if you just want to do self-study. So all my resources, all my demonstration videos, which are on YouTube, and lots of other helpful resources and scenarios for you. Please feel free to email me on hannah.lames@outlook.com.